Oh, it's an honor to be here today. I have no conflicts of interest or to resolve at all. I'm a neonatologist. I began this through the eyes of my patients. Traditionally, we're trained to take care of infants that are very small or have severe birth defects. But we started seeing a different group of infants in our unit, and those were infants having opioid withdrawal. And that really began the journey for us in terms of our clinical work as well as our research. You know, as we think about the opioid epidemic, it's grown to affect nearly every demographic in the United States, including pregnant women, children, as well as infants. Because healthy children grow into healthy adults, it's imperative that we consider the entire life course. When I encounter pregnant women at Vanderbilt, they don't start using opioids when they're pregnant. They start well before. And we know this bears out in the literature, too. Of those in treatment today, 2/3 of people began first use before age 25. A third began first use before age 18. So we have to really look at the life course. We know there's substantial room to grow when we think about needs for both pregnant women and infants. We see increasing rates of both opioid use disorder among pregnant women and adolescents. For youth less than 25, we've seen a 6-fold increase recently in rates of opioid use disorder, a similar increase among pregnant women delivering, with a 6-fold increase in opioid use disorder at the time of delivery. And still, our delivery of opioid agonist therapies to these populations remains substantially inadequate. Among youth, both commercially and insured by Medicaid, only about a quarter receive opioid agonist therapies, and for adolescents, it's even worse. About 5% in Medicaid receive opioid agonist therapies that have an opioid use disorder. Pregnant women in treatment, about 50% receive an opioid agonist therapy. When we think about workforce for this specific population, there's a need to enhance developmentally appropriate strategies for prevention and expansion of treatment and improve training in medical schools as well as obstetric and pediatric residencies on both train and addiction. The SUPPORT Act, which was signed into law last week, does have a provision specific to medical students to be waived, and it does have a specific emphasis also on pediatrics. There is substantial stigma about trading one drug for another, and I think we talk about stigma a lot. Pregnant women in particular are stigmatized in this space. The language of how could you do this to your infant is pretty broad. And we really do have to have broad public as well as provider education around the role of opioid agonist therapies and their potential benefits. In addition, only about 2% of DATA waivered providers are pediatricians or obstetricians. And if we look the other way, if we look at how many obstetricians or pediatricians are waivered, it's less than 1% in each group. We need more generalists to be waivered, as well as more addiction medicine trained folks in pediatrics and as well as obstetrics. And of course, expanding the roles of both PAs, midwives, and nurse practitioners. And that's not discounting the fact that many families can be seen by both family medicine docs as well as FQHCs. But we don't have a lot of good data to understand their current role. Well, one thing I wanted to focus on are the effects on infants, because this is primarily where a lot of my work is. It's worth reviewing the benefits of opioid agonist therapies for pregnant women and its effects on infants. Buprenorphine and methadone are the medications that are primarily recommended for the use of pregnant women. And yes, we know, as it's been said multiple times today, that there are benefits for the pregnant woman. It decreases her risk of overdose death, relapse, as well as HIV and hepatitis C. But for the infant, there are substantial benefits as well. The infant is more likely to go to term and have higher birth weights. This does come with some risk of having drug withdrawal. But what's important is that 25-week babies that I took care of on Saturday night in the hospital, those babies are too young, too immature to develop signs of drug withdrawal. So we are trading this preterm infant that we may have if a woman is in active relapse or active opioid use for an infant that's more likely to go to term but still have drug withdrawal. And we know the adverse consequences of a 25-week delivery, whereas we know that generally babies that are born at term and have drug withdrawal do well. Neonatal opioid withdrawal syndrome is a drug withdrawal syndrome that newborns experience shortly after birth. Not all of them do. It generally appears between 24 to 72 hours. The common clinical signs are GI signs, poor feeding, loose stools, and poor weight gain. CNS signs are tremors, hypertonia, and irritability. When I'm describing it to the public, I usually describe it as a colicky baby times 5 because I think we can all relate to that if we've been parents. The treatment of choice first is to modify the environment. You can imagine most neonatal intensive care units are loud and chaotic environments. We may have a baby on ECMO next to a baby having drug withdrawal, and that's not the most optimal place oftentimes to go through drug withdrawal. For severe neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, we treat it with an opioid like morphine or methadone. We're seeing a shift in the way we care for this. Traditionally, we have over-medicalized this, and the traditional path is like this. We transfer an infant to a tertiary care facility, we separate mom and baby, take the baby to a NICU, we treat the infant completely separate, we don't allow moms to breastfeed, or we're at least inconsistent about it. We focus on the correct medicine as opposed to the correct care process. Burnout among providers is common, there's a lack of trauma-informed care. And care is not standardized, and this has resulted in long lengths of stay. On average, nationwide, for infants that are treated for drug withdrawal, they stay more than 3 weeks in the hospital. The newer care models are more inclusive of mom's needs, not necessarily transferring to a tertiary care facility, keeping the dyad intact, treatment inclusive of the mom, breastfeeding is encouraged and supported, focusing on the care process, not just the medications, and encouraging staff to do trauma-informed care, standardizing care. We've done this at Vanderbilt, and we've had about 150 infants born in our hospital that are opioid exposed greater than 35 weeks in the last year. We've seen a massive reduction in length of stay. Average length of stay for us right now for all comers is 5 days. And among the moms that are eligible to breastfeed, because we're supporting them now, 80% are using some breast milk at the time of discharge. So closing with workforce that's specific to this population. I almost shut the whole thing down. First, throughout everything has been mentioned multiple times, focusing on stigma, trauma-informed care, standardization, as well as improving collaboration. But there are some really unique needs for pregnant women and infants, and I applaud the committee for talking about both children and pregnant women. In the neonatal period, focusing on rural hospitals, we know that rural hospitals, rural communities have been disproportionately affected by opioids. We need to help support them with resources and perhaps telemedicine. Changing the environment, allowing space for rooming in, we know that makes a difference for the dyad, as well as building and enhancing support for lactation and child life. There's a lot of providers in childhood and beyond, including engaging our child welfare system that has increased. We have 400,000 children in child welfare today. A third are there because of parental substance use. Early intervention services, home nurse visitation, WIC, Head Start, as well as the pediatrician. There are large gaps throughout, and I hope that this begins a framework where we can have a robust discussion about the needs that are there moving forward. Thank you for your time.